All right, so now we'll go to the carotid artery and we'll discuss about the mesenteric artery symptoms as well. So can someone describe the carotid artery symptoms? We do a lot of carotid artery endarterectomies. Why we do it, and what are the symptoms? So stroke is a big symptom. Anytime a patient comes to the stroke, we are not called for an endart. The stroke team is called first. They evaluate the patient. Okay, good. So TIAs. How do you define a TIA?
Duration of symptoms.
So what are the symptoms? It's very important. We treat a lot of patients, and a lot of times we get called from ENT folks, and we get called from medicine docs, like this patient has stenosis, has carotid artery stenosis. Would you fix it for tinnitus? Would you fix it for vertigo? Would you fix it for syncope?
I think it would, this is warranty getting a carotid ultrasound to see what.
So syncope, to me, the first issue is it's coming from the heart. Usually syncope, dizziness, vertigo, they are not carotid artery symptoms. You have to rule out everything else if you want to, like you cannot, on the basis of the patient has syncope, let's do a carotid artery surgery. No. So usually they have focal neurological symptoms. They are sudden in onset, and they are referable to the appropriate carotid artery distribution. So for example, the patient has a right carotid artery, severe stenosis. Patient has a TIA, what kind of symptoms the patient will have?
Left side weakness.
So basically the symptoms are weakness in any of the extremity, slurring of speech, difficulty finding words. It's very important. What else? And ipsilateral eye symptoms. Transient loss of vision in one of the eye. They'll describe as like curtain coming down. And it will resolve like very rapidly. So that's called as amaurosis fugax. So focal neurologic symptoms are sudden onset, referable to appropriate carotid artery distribution, one or more TI characterized by focal neurological dysfunction and transient mononuclear blindness. Stroke is a kind of symptom, but you have to see, like you cannot operate on acute stroke. You have to see if the patient is getting better, and the window time is within 2 weeks you should operate. Because if you do not operate within 2 weeks, what will happen is the risk of another disabling stroke is extremely high. So within 2 weeks you operate emergently on crescendo TIAs, like which fluctuates too much, like the symptom comes, the resolves, and symptom comes, and it's like getting worse, and can goes and comes back again and again. Those kind of patients, like they embolize from the carotid artery, so you have to operate them on early.
What is it appropriate for a trauma patient with a fall to get a carotid artery ultrasound? Like we get patient with fall, patient fell, we don't know the real mechanism, and usually we get a carotid ultrasound. Do you think it's reasonable to do it? Or?
It all depends, like age, how the physical examination is there any carotid artery like bruit on that patient, and
sometimes we get a pushback, as you said, syncope is not caused by...
Right. But I don't think so. It's first test to start to
we do
for workup.
The cardioarterial, we
Yeah.
look at the heart and then the stenosis stuff, and then go to the carotids.
Right. So as we discussed, vertigo and syncope are generally not carotid artery symptoms, and tinnitus is also not usually a carotid artery symptom. We have one patient in the clinic. I'm following. She has tinnitus and she's been referred by head and neck service.
Technical.
So why we operate on the carotids? A lot of patients are asymptomatic also. So what are we trying to prevent? So you do carotid artery surgery, you do carotid artery stenting to prevent stroke. So what is the main complication of the operation? So you can cause a stroke. So this is one of the kind of surgery which you have to be sure and that this is the right indication for the operation. So you're trying to prevent a stroke, but you can cause a stroke. So so these are the basic trials that you should know. I think so in general surgery also, especially North American surgery carotid endarterectomy trial and asymptomatic carotid atherosclerotic study trial. So in NASCAT, the symptomatic patients with carotid artery, they divided into two parts. One is greater than 70%, but main point is symptomatic patients. And another category is 50 to 69% symptomatic. So you look at this stroke rate. BMT is best medical therapy. Best medical therapy includes aspirin, statin, and control of your blood glucose. So, but no surgery. This column is best medical therapy with carotid artery surgery. So look at this, 26% stroke rate 2 years, drops down to 9% in 2 years. This is the number you have to remember, 26% and 9%. And if you look at the 5 years, 28% and 13%. So the conclusion was CEA is beneficial for symptomatic patients with greater than 70% carotid artery stenosis with a p-value of 0.001. So same lines, if the stenosis is 50 to 69%, the stroke rate 15% would drop down to 9%. Again, CEA is beneficial for those patients. And these are for symptomatic patients. Similar results were found in European trial as well. So you can talk about the symptomatic patients, and now if we come to asymptomatic patients, so the stroke rate with best medical therapy is 11%. So that's how you have to explain it to the patient. If the patient is asymptomatic in your clinic, they will ask oh, I don't have any symptoms, why are we doing this operation? You tell them 5 years, the stroke rate is 11%. If we do the surgery, it drops down to 5.1% for 5 years. Again, CEA is beneficial for asymptomatic patients greater than 60% carotid artery stenosis. So it all depends. So a lot of it's physician-based practice also. So a lot of physicians, they go up to almost if they've lost 80% stenosis before they operate on asymptomatic. There is a CREST-2 trial going on right now, and I think so for the guidelines for asymptomatic carotid artery stenosis, they're going to be very, very limited especially for asymptomatic. Because why would we think the endarterectomy will be very limited for asymptomatic people? No, so the question is exactly. So the medical therapy has increased, aspirin, statin. A lot of patients are being followed aggressively by cardiologists, by medicine doctors, and given that it's getting so much better, that we would see in future, depending upon the CREST-2 trial, that the surgery for asymptomatic will be very, very limited. I think so the indication might go up to 90% stenosis before you operate on an asymptomatic patient, because the risk of stroke is high. So keep this number in mind, 26% 2 year drops down to 9%. This is NASCAT. Then ACAS, 11%. This is asymptomatic, 11% to 5.1%.
I was asked this in my oral reports. They presented me an asymptomatic carotid artery stenosis, and as whatever it said, that why you want to operate, why you don't want to, and they wanted me to quote this trial. Just the name and just the numbers. Very important. That's it.
These are landmark trials like in vascular surgery. So coming to the guidelines, so again, cardiologists, they have a different opinion. Lot of papers on, like we can talk about like whole day about carotid artery stenting versus doing endarterectomy. So the cardiologists, they say all the studies so far have shown the carotid artery stenting is not inferior to endart, but they do not say it's better. So the wording, it's very political. It's extremely it all depends where the paper is coming from. Is it coming from the medicine folks or is it coming from the surgery folks? So surgery people will always say like a carotid endarterectomy is better. And they will say the stent is non-inferior, so they can keep doing the stents. But anyways, so SVS guidelines, SVS is the Society for Vascular Surgery. For symptomatic patients, CEA is preferable in patient 50 to 99%. Carotid artery, CAS means carotid artery stent in hostile neck and severe uncorrectable cardiac conditions. And those patients you do a carotid artery stent. And this is symptomatic, 50 to 99%. Asymptomatic CEA in good risk patients with 60 to 99% stenosis. But you have to look at it 3 to 5 year life expectancy and make sure the complication rate is less than 3%. So if the patient does not have a good life expectancy, she's like bedridden, and you go see the patient in the clinic or in the hospital, would you offer an asymptomatic patient carotid endart surgery? So you have to look at overall. So we treat the patient, don't treat the ultrasound, don't treat the scan. For example, a lot of times we get a call from the medicine, like this patient has 80% stenosis, and then you go see the patient, like patient can hardly walk, patient is bedridden. So we have to decide whether we're going to do the surgery or not, depending upon the life expectancy. And there is insufficient data to support CAS. Outside trials may be used for selective interventionalists with established complication rate of less than 3%. And high risk patients should have only best medical therapy. They're extremely high risk, but they are asymptomatic. For symptomatic, you will have to do something about those patients. So these are the guidelines we follow. But for asymptomatic, it all depends. It's again physician to physician. So where I trained, we almost went to like 80% before we operated on asymptomatic. So what are the indications for carotid artery stenting? So where is the carotid artery bifurcation in the neck? C2, C3, midpoint of the neck. They're easily accessible and that. So if the lesion is like above C2, C1 lesion, then it's hard surgically to get access. There are different maneuvers you can do surgically also. Anyone knows any of those maneuvers?
Disarticulate mandible.
Nasotracheal intubation, disarticulation of mandible. You can do those things to get to the C1 level. Or if the patient has radiation-induced stenosis, it's hard to dissect the neck. Nerve injury is extremely high in those kind of cases. Or if it's a redo carotid, again, the nerve injury is extremely high with the redo carotid. Or if the patient has a clinical significant cardiac or pulmonary disease, that precludes you for us to do a general anesthesia on the patient to do a endart. So these are the indications for carotid artery stenting, and which we very closely follow. We do not stent an asymptomatic patient we make sure these are the things present before we stent the patient.
Just a question. When you say radiation-induced stenosis, what happens if they just have stenosis and they've had, is that the same thing as them having stenosis, just natural course, and having radiation to the neck?
Yeah, radiation to the neck or radiation-induced stenosis. It's similar because the issue is like extensive scarring, fibrosis, nerve injury complication is extremely high with those kind of scar in the neck. So what would you do in this patient? He's symptomatic with amaurosis fugax on the right side. His creatinine is 3.9. He has a history of 2 CVAs in the past, severe restrictive lung disease, hypertension, diabetes, CHF. His BNP is 12,000. His CAD, dual chamber pacemaker for symptomatic bradycardia. So this is a real patient we have right now.
We stented him, yes.
Yeah.
Stent and deal with the renal complications if they happen.
So you consult nephrology pre-op. That's a good question. So his creatinine is 3.9. What would you do pre-operatively? So he's having symptoms in the right eye. So he's symptomatic right carotid stenosis. So then you talk to the patient. You explain them the risk, complications involved, and so you give them the options that ENDART versus stent, which one is better. And you always think like, what would I do if this patient is my family member? Always, like, especially like surgical field, always think like, what would you operate on this patient if the patient is your family member? What would you recommend? So pre-op optimization of the renal function is extremely important. So you consult nephrology, pre-op hydration, mucomist, plus minus it works. And then you try to limit the contrast. You try to use half-strength contrast during the case. And how else you can avoid the contrast intraoperatively? CO2 will cause embolism, like stroke, and you don't use CO2 above the diaphragm. So usually, so how are we going to get to the carotid artery from the groin? So we usually do an arch angiogram and then we go to the carotid. So you can skip the arch angiogram. That's what we did. We did not do any arch angiogram yesterday. So you know where the carotid artery is coming. So you know from your pre-op ultrasound that patient has a carotid artery stenosis on the right side. So you try to manipulate, like put your catheter in the arch and you try to see if you can cannulate the right carotid, like the innominate artery. It's kind of like blind move, but most of the neurointerventionalists, like whenever there's acute stroke, they don't do arch angiograms. They just go like straight. So you avoid almost like 30 ml of contrast is used for the arch angiogram. So you all avoid that much of contrast. And then you just do like a little bit injection, like in the selective, you selectively catheterize your right carotid artery and then you do angiogram selectively. So this was a patient we did yesterday, had a right proximal internal carotid artery disease, severe stenosis, and this is the sheath in the right common carotid. So we placed a filter here. This is for protection, and you will not get reimbursement if you do not use a filter. But the filter is for protection for any debris that goes when you try to stent it or do angioplasty. So you have to be very careful. These are not benign procedures. The risk of stroke is extremely high with stenting as compared to ENDART. ENDART, we have control over the artery. As surgeons, like we all like ENDART is much better. You have good control of the artery. You can clamp, back bleed, flush. But if the stroke happens here, because of the everything when you pass through this, there's a potential of causing embolization. So you have to be very careful. So the lesions which are more prone for embolization, if they are heavily calcified, circumferential calcification, or when you have to pre-dilate the lesion. Pre-dilate the lesion means before you put the stent, it's so tight that you have to like inflate the balloon. The moment you inflate the balloon, some of the debris, you guys see in the open arteries, right? So see the amount of black, and you see putting a stent in it and trying to like angioplasty, that like sclerotic plaque is going to break and cause a stroke upstream. So that's why you put the filter in. And then we deployed the stent. We did not have to pre-dilate, and we placed the stent and then angioplasty the stent with a small balloon. And we have good flow in the distal IC. So again, this was to demonstrate like sometimes you have to do it because depending upon the physiological risk of the patient. This was not because of the anatomy of the patient. This was because of the physiological risk of carotid end arch surgery on this patient. So nowadays, other thing we have seen is, I think so for all residents is very important. Like almost every other patient is Plavix resistant. So you have to put them on some other antiplatelet agents like Brilinta. So make sure they are like they have full coverage. And these patients, especially if you're doing an end art or you're doing a carotid artery stent, make sure they are on antiplatelet on the day of the surgery also. A lot of patients in the pre-op, or the nurse is like, oh, stop aspirin and Plavix 5 days or 7 days before. Do not do it for carotid artery surgery. Always, whenever you pre-op the patient in the pre-op holding, make sure you ask them, did you take your aspirin? Have you been taking your aspirin or Plavix, whatever the patient is on? Because I would cancel the surgery if the patient is not on antiplatelet.
What is the minimum amount of time you want them on state Plavix? Is it 2 weeks or a week? Or, I mean,
it all depends. Like sometimes not all the patients are on Plavix. It all depends like degree of stenosis or whether they've been taking, sometimes they are taking Plavix for some other like cardiac reasons. So I would continue the Plavix and aspirin on most of the patient depending upon the stenosis. And especially like 7 days. The problem comes is when you do the surgery and you see platelet aggregation right in front of your eyes, the moment you close the artery and you come out of the operating room, that patch is going to thrombose. And it's going to be extremely difficult to salvage. So that's why it's very important. That's why we waited yesterday, because the patient had not got Brilinta that morning. So there is a small things which you have to be, so any pre-op note, I usually like when in fellowship, like patient is on aspirin and Plavix, so we don't miss it. So we don't like next time if the patient comes with carotid end art, make sure patient is taking antiplatelet. And most of the physician, like sometimes some of the physician will give them like a heavy loading dose of aspirin or Plavix and then do the surgery. And a lot of physician will cancel the surgery and then bring the patient back. But you're doing it for asymptomatic, right? Sometimes. So asymptomatic patient, outpatient surgery, already the risk of stroke is high. And the patient is not on antiplatelet agent, that is going to increase the risk of stroke intraoperatively or perioperatively. You don't want that risk. So the best thing, the safe answer will be to cancel the surgery, bring the patient back.
do you test people these days to see if the Plavix will work?
Yes, we've been testing, and almost every other patient is Plavix resistant. 1/3 of the patients in one of the study has Plavix resistance. So especially the patients who have carotid artery stents and mesenteric artery stents, I think so it's very important for those people to be checked.
How long does it take? Once you put the stent in, how long does it take
So a lot of these patients are complicated, like CAD, so I usually tell them to take, like if they have a heart stent or something, like lifelong. Aspirin is for life. Plavix, it all depends, like 3 months, 6 months, like depending upon which arterial tree you have intervened. But there is no book answer, like, oh, you do it for 1 month or 6 months. All right, so we'll touch base on the mesenteric artery disease as well. I just wanted to go over the anatomy. What is the first branch of SMA? Anyone?
Inferior pancreatic model.
All right. What are the other branches of SMA? So MRI, right? We order MRI every other day. So M for middle colic, R for right colic, I for ileocolic artery, right? MRI. So the first branch is inferior pancreaticoduodenal artery, and then your MRI comes. Middle colic, right colic, ileocolic. And then you have jejunal and ileal branches. So branches of IMA. So these are very important questions. These can be asked on the app site as well. IMA is your left colic, your sigmoid, and superior rectal. Most of the time they ask questions where the middle rectal and inferior rectal comes from. So that's from your internal iliac artery. And what is arc of Riolan? So it's a connection between your SMA and your IMA. And this is the marginal artery of Drummond. So mesenteric artery symptoms, they can present with acute mesenteric artery ischemia or chronic mesenteric artery ischemia. Acute mesenteric artery ischemia will be pain out of proportion to your physical examination, acute onset abdominal pain, severe excruciating abdominal pain. On physical examination, you can have peritoneal sign. But for chronic mesenteric artery symptoms, usually they have recurrent episodes of pain after eating, and mostly it is called as intestinal angina. Pain is dull, crampy, postprandial abdominal pain, and usually happens within the first hour after eating. And the pain usually subsides over the course of next 2 hours. So what do you think the etiology of the pain is in mesenteric artery ischemia? So there is a mismatch between the splanchnic blood flow and the intestinal metabolic demand. So that's why you have symptoms of the mesenteric artery stenosis. So what do you do when you get the patient, let's assume this patient has acute mesenteric ischemia. How do you handle the patient in the ER? The patient is in the ER. We have a similar kind of patient a few days back. What do you do? All right, I'll just go over one slide and then I'll send you these slides. So basically, 2 ways to expose the SMA: anterior approach and lateral approach. The anterior approach, you pull up your transverse mesocolon up, small bowel on the right, go to the root of mesentery and palpate the artery if you have a palpable pulse, or you score the peritoneum with your electrocautery. Sometimes there is an anterior jejunal vein branch you have to ligate, and but your your SMV will be to the right, artery will be to the left, and then you expose your artery, control the jejunal branches with the vessel loops. So this is your anterior approach. The lateral approach is you have to divide the ligament of Treitz to get from the lateral approach, the way we had it exposed yesterday while doing a aortobiofemoral bypass. So anterior approach and lateral approach, and as Dr. Samra had said last time, sometimes you follow the middle colic artery also if you're having difficulty finding the SMA, and then you can trace it down to the origin on the SMA. So a few slides are left to be discussed. I think so I'll email it to you guys. Thank you.